I think the fact that Rich and I are doing a double act is a real sign to how to make complex programs like this, you need a balance of clinical and scientific superpower and also operational mentality. And so that's kind of why we're kind of coming to you, both of us, today. So the first thing I would say is one of the things I find fascinating at these conferences, and last year, was the differences between the different studies we're running. And I think one of the things that really has influenced how we've approached the delivery of the Generation study is the fact we have to think about it at a national level. Our funding comes from the Department of Health, and we're very much looking at this about how the potential for this to be rolled out nationally across England. And that means that it influences how we have to think about that study design and delivery, which creates its own tensions between how we design it as a study versus thinking about how it could work at a national level. We established quite early on a 3-point vision for this study. And I think the first aim that's outlined on this is very much in tune with everybody else. We really want to understand how you can use whole genome sequencing to find babies with rare diseases before they get ill. I think the bit that really is different in this is we are very much doing this in partnership with the NHS. And so we are running it together with them. And again, that aspect of both thinking about this nationally and with the NHS and thinking about how we design this in a way to also understand how this would impact the NHS and NHS pathways means that we've had to think very carefully, and that's influenced some of how we've had to think about that design. Beyond that, we have 2 other aims that we felt was really important to set out with this study. The second was really understanding how we can link babies' genomic data with clinical data from the baby's lifetime and to create a research resource for researchers to access it, to use it, to answer other questions. Now, this is something at Genomics England that we've had a track record in doing for a while. I think the important thing to note here is that we're asking for parents of babies, both who we find a condition for, but also who we don't find a condition for, to allow us to do this. And that means that some of those motivations, those parents, are very different. If you have a baby with a condition, you've got much more vested interest in that research. And so we've had to think very carefully about what that should look like and what some of the subtle differences about how we might think about that data. And that's also been part of our thinking. I think the third aim for us has really been very much recognising that if we are all successful and we enter into this world where genome sequencing is done at birth, that raises a lot of potential for a genome to be used throughout the course of an individual's lifetime, potentially for more screening, pharmacogenomics, further diagnostic use. And actually, we really need to think about what the risks and benefits of that is, and actually start to think about what that world could look like. We don't think we're going to crack it through our study, but we think it's really important that we start having the right conversation to ask these questions and invest in doing that with both the public, but with also a lot of stakeholders across the ecosystem. I'm going to move on to just briefly touch upon kind of our study design. What you'll see on this slide is we very much based it on thinking about how it's going to work from the participant's experience. And that's very much because the way we've approached the design is co-designing this with members of the public, potential parents, people from the rare disease community, and all different clinical stakeholders. So just to kind of briefly whip through some key elements I think it's important to draw out. We will be starting to talk to mums from 20 weeks of pregnancy, but we will be taking consent around 36 weeks. One of the really big differences between us and other studies perhaps is the sample type we're taking. We did some feasibility work, and what we realised is that whilst dry blood spot cards can work, when you're thinking about this at a national level, you have to think about variation and the fact that this is going to work across a network, and that creates a lot of variation in how samples are taken. So when we did the feasibility study, we discovered that actually cord blood was more robust for that. So we're actually going to take cord blood as our primary sample. We know there are some cases where we won't find it. So in those cases, we will take dried blood spot into a capillary tube. I'm just going to really quickly whip through because I'm very conscious of time. We're going to be sequencing and doing our sample processing through a central place. Rich will touch upon in a minute about how we're approaching the analysis, so I'm not going to go into that. I think the other key points to sort of draw out here is that we very much built on screening best practice when thinking about how we return those results. So we will be providing letters or emails back to parents where there's no conditions, but actually in cases where we find something, we are going to be having direct contact from a specialist team who will be ringing that parent to tell them that we suspect that baby has a condition. And we're working very hard with the NHS to really understand that whole process and that entry into clinical pathways. I'm just going to briefly touch on the locations. This is England-wide. We think that we're going to start with about 14 trusts across England initially, but that might have to scale up to somewhere between 25 and 40 to deliver the 100,000 we need. We're thinking very carefully about who those trusts should be, with a mixture of places with big birth volume, diversity, and there's quite a lot of tensions about making sure we can deliver the numbers, but also the diversity we want, but also stress testing the model. And those are all things we're having to consider about where those sites should be and how we scale this up. I'm now going to hand over to Rich, who's going to talk to you a bit more about the conditions and how the analysis is working.
Thank you. Thanks, Alice. And I think maybe just as context to some of the details I was going to share with you, I think I just wanted to highlight a couple of words that we've heard quite a lot this morning and are quite easily said, but I think they mean an awful lot in the context of the big questions we're trying to ask. And I think that's collaboration and partnership. And I think that's what this meeting is about. This is very much a team sport to try and answer some really big questions and to set ourselves up in the longer term to continue to have the best information we can to drive the best policy to get the best outcomes. And that partnership for us is including with many of you in the audience who are designing similar programs, inputting to our program. It's also with the National Screening Committee, who, as you've heard from Mike, have been integral to designing the program with us. And as Alice has said, with the NHS, who have been there just the same in delivering the program, that partnership is absolutely crucial for the national scale that we have a real privilege to explore. But it's also there in the design, and I can see in the audience a good number of the experts who've been there on the journey with us as we design the program. You can read more about our program in our protocol, which is available online. And the other part of this partnership, which is absolutely crucial, is with the public and with patients and those views. This slide talks to you about how we've gone about the process of deciding how to select the conditions to feedback, working with experts to get their views, working with the NHS to identify how practical that is to deliver in the NHS with the policies in place, with the clinical pathways as they are, and also working with patient support groups and participants and people with lived experience, as well as people who might be joining the study, to understand how we go about that. I think when one thinks about designing a research study, there are many research studies in this world which are best done with a door closed, a desk, a cold flannel on your head and some bright ideas. That gets you a long way. It gets you a long way in a lot of research, but it's not how you do this sort of research. And I think that word partnership and designing things together, learning things together. And as Mike said, a lot of this is about going on a journey in a societal context and really making those decisions together. So we've been going through that process for the selection of the conditions. Earlier this week, in fact, we released the provisional list of conditions we're looking at. And one of the things we're really enjoying doing is through that is talking to participant groups and also to others in this room, comparing that list, thinking how we iterate it, thinking how we learn from each other, understanding why we've made different choices. That process, as you saw on the slide, is multi-step. It's working through each of those different stages, putting in place the governance that can be explainable, sort of understandable, and also puts in the safeguards for us in terms of making the right decisions. And we've thought about that in very across the whole program in the different elements that there are there on David's slides, on Robert's, on Mike's. You saw many of the questions that we're exploring, and really our job here is to construct studies which are deliverable, which do right by the patients and participants in them. As David said, this is a research study to answer questions, and these people are not just participants in research. They're families that we need to consider how our actions will play out and maximize the potential benefit, minimize potential harms for them. And so constructing that governance in all areas, and this slide highlighting the choices that we're making around variant prioritization, the automated process that we will use, that we believe if this is something to be adopted, this isn't something which can rely in large part on manual inspection of variants. This is something where we need to think how we can automate in the right way the large majority of the processes that take place. The approach we're taking is very similar, actually, to a number of the other studies that we'll hear from here. Is conservative, and it raises really important questions about how we get the right balance that we'll learn during all of our studies between sensitivity and specificity. And again, that's a really important area for discussion and openness with participants in the programs, helping us choose what the right approach is. So I hope that's given you a flavor between myself and Alice on the ethos of this study, where we, like you, are really excited about this journey. We feel a pressing need to ask these questions, not to sit and leave them unanswered. But we also feel a real responsibility to do this together and to make the right choices according to that broad perspective, not just some bright sparks in a closed room. And that's very much what we seek to continue to do. In terms of the timelines of our study, we've just released the list of provisional conditions. We're seeking feedback on those, and we're in discussion with patient support groups as well. Later this year, we plan to launch recruitment at the first site, and then recruit, as Alice said, across a large number of trusts, expanding up during next year, so that we can recruit those 100,000 babies we're very fortunate to have joining our program. So thank you very much. Really look forward to spending time with you all over the next couple of days and to some great conversations.